Good morning, all of you. Welcome to the CPD webinar series organized by the Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. You will instantly receive the certificate once you fill the Google form. So kindly use the format of initials followed by name without any prefixes. These rules are to improve and maintain the standards of the CPD programs conducted by Shri. So you can ask any question at the end of the webinar. And also, if you have any question, you can please type it in the chat box. And even after that, if you have very special questions, you can email us on our email office313@gmail.com. And we have very exciting news for you all. The Education, Training and Research Unit of Ministry of Health has taken an initiative to provide you with an important certificate for these all CPD followers of accredited CPD programs. So a circular has been issued by Ministry of Health dated 9th of October 2023. So according to that, we are very happy to inform that all followers of Tree Knowledge Academy will be received CPD certificates, and you have to fill a link that is provided by the Ministry of Health with your details on or before November 2023, 15th of November 2023 through the link, and this link will be posted in our Zoom chat and also in our WhatsApp chat. So today's topic is painful perianal conditions, a clinical important topic in surgery. So let me introduce our guest speaker today. He is Dr. V.Thusyanthan. He is currently acting as the consultant gastroenterological surgeon at the Teaching Hospital, Jaffna. Dr. V.Thusyanthan obtained MBBS and MD surgery from the Colombo University and MRCS England, and he was a senior clinical fellow in upper and lower GI surgery at Broomfield Hospital, UK. Over to you, sir.
Thank you very much for the kind introduction. First of all, I would like to thank the organizers for offering me this platform. Traditionally, surgeons are interested with the care of the anus-related conditions and problems arising from the surrounding tissues. Unfortunately, we are interested with the dirtiest part of the trade of medicine, and I hope all of you will agree with me. However, we do our duty with dedication so that we keep the backyard of patients tidy and healthy, so our colleagues hailing from other specialties can enjoy the glamorous part of the trade of medicine. Today, I would like to focus on painful perianal conditions. The outline of my talk will be evolving around the clinical painful perianal conditions. Just to refresh your knowledge on the anatomy of anal canal, to name certain reflexes and specialties related to defecation and other associated reflexes of the anus, discuss clinical management of very common painful perianal conditions. Let's move on. A patient who is having very severe pain at the anus or in the surroundings will be readily coming to us and elaborating the nature of his problem. But due to social stigma and other various reasons, patients who are having bearable pain or mild to moderate pain try to hide their symptoms, or they may not be coming out with full picture of the clinical problem. So it is our duty to maintain high index of suspicion and explore the symptomatology of the problem and offer treatment. Otherwise, we may miss a crucial diagnosis and patient will go on suffering. The manifestations of painful perineal conditions are not confined to anal canal because these manifestations can be an end result of other various systemic diseases. For example, painful perianal fissure may be the first and sole presentation of a parathyroid adenoma or hypothyroidism. So, whenever we are dealing with conditions of painful perianal diseases, we should focus on whether we are having any leads to any other systemic diseases. That's why this topic gets its important to medical officers, consultants, and other clinicians who are dealing with other clinical or medical arenas. Actually, whenever somebody comes with painful perineal conditions, we have the tendency that we'll be focusing on the current problem only. But there may be an underlying sinister pathology like inflammatory bowel disease or colorectal malignancies. Here in our country, we do not have a systematic screening program for colorectal malignancies. So it is our duty to explore the symptoms and find out actually whether the patient is having painful perineal conditions only or whether there are any associated sinister pathology like colorectal malignancies. We offer multiple treatments for various other disease conditions, which can end up with constipation, and in return, patient may come with anal fissure, painful external thrombus hemorrhoids, etc. So it is imperative that we should inform our patients and alert them, look, I am going to prescribe you this medicine, or I am going to offer you this treatment, so you may end up with this problem. So the patient will be alert and they will seek out medical attention immediately whenever they develop the symptoms related to these conditions. Anybody who had painful perineal condition will readily admit how it worse or agonizing pain it had been without treatment. So, whenever we detect these conditions early and offer prompt treatment, most of the time we will be able to ensure the restoration of the quality of life and early return to work. So, in a way, at this national economic crisis, we may be able to contribute to the country as well. This is a simple line diagram of anal canal. So, the lower rectum eventually turns into anal canal. You can see the rectal wall converts itself into internal anal sphincter, and you can see the three components of the external anal sphincter: superficial, subcutaneous, deep, which is confluenced by the puborectalis ring of the pelvic floor. I would like to draw your attention two sets of venous plexuses mentioned here. One is external hemorrhoid, you can see at the bottom end of the image. Another set of venous plexuses, named as internal hemorrhoids, can be seen at the top end of the anal canal. Here you can see the very important line called dentate line. This dentate line is the demarcation point where the somatic nervous supply is somatic nervous supply is for the area of the anal canal below the dentate line, which is highly sensitive. Actually, the portion of the anal canal above the dentate line is receiving visceral nervous supply and relatively insensitive. I would like to just tell about the names of the defecation and associated reflexes. Actually, it's a complex mechanism. It is coordinated by intrinsic defecation reflex, parasympathetic defecation reflex, and our voluntary control. Actually, it is a conditioned reflex mechanism where we have conditioned ourselves to go ahead with the defecation whenever it is socially acceptable. The next flow chart is showing you the steps of defecation reflex, how it is initiated and how it is executed. But I don't want to go into each and every steps. It is just for your knowledge. You can always refer from the reading materials. But I would like to draw your attention over a very specific thing, that is the mucosa that is lining the lower rectum and the upper end of the inner canal is very specialized. Whenever the rectal contents are presented to that region for initiation of the defecation reflex, the mucosa can analyze the nature of the content, whether it is gaseous, fluid, or solid. Whenever it is convenient, we can go ahead with defecation. Otherwise, we can selectively release gas without leaking any solid or liquid. That's why we are unable to replace this mechanism by any other means so far. So, whenever we are dealing with perianal conditions, we are very careful not to tamper this aspect. Obviously, painful perianal conditions will be presenting with pain. There's no doubt. Actually, good old clinical textbooks will be telling that diagnosis of perianal conditions is made at the lobby of your surgery, not exactly on the examination couch. Not only the pain, the patients may come up with either lump at anus or ongoing pus discharge through the anus or through the openings closer to the anal opening. They may be having either fresh or altered bleeding. They may have tenesmus, the continuous ongoing urge to pass stools even after emptying rectum. There may be alteration in bowel habits. At times, patients present with urinary retention. Because we all know the urethral sphincters and anal sphincters share the same autonomic outflow at S234 level. So, due to referred pain, any pain in the anal canal or immediately after a surgery like hemorrhectomy, an elderly patient specifically can go into urinary retention. So, in a patient who are coming with acute urinary retention, we should focus on whether patient is having any painful perineal conditions as well. If there's an inflammatory or infective condition going on, patient may present with fever also. As far as assessment is concerned, based on the clinical assessment, we will be able to identify the most probable or a possible diagnosis. So we should obtain a detailed history, the duration of the pain, nature of the pain, and associate other symptoms I mentioned in the previous slide, so that we'll be able to arrive at a diagnosis. We can simply confirm the diagnosis by visual inspection. An external perianal hematoma or fissure are readily visible. We always emphasize no examination is complete without digital examination. But painful perineal conditions are an exception because patient is already in pain. If we poke anything into the anus, it will be aggravating the distress. So it's not ethical or inhuman. It's inhuman to go ahead with digital examination. So we tend to avoid that. Same applies for proctoscopy also. Based on our clinical assessment, we can decide on the investigations. If there's an inflammatory condition we are suspecting for, we can go for full blood count, CRP, etc. Or if there is associated constipation, we can go for thyroid function tests, etc. But at the acute stage, these investigations may not help us at all. Later on, we can offer certain imaging modalities. In acute settings, we hardly use any imaging modalities. But if you are not sure about any diagnosis, we can go for endoscopic ultrasound scan to rule out any intersphincteric abscesses or abscesses which are deep-seated into the pelvic cavity, which may present with pain over the anus or perineal area. MRI pelvis also may help us in terms of assessing the fistula tracts and associated abscess collections. For the reasons I mentioned above, we tend to defer the endoscopic assessment also due to pain. But sometimes we may have to go for an emergency endoscopic assessment as well. The main objective of doing endoscopic assessment is to rule out any associated pathology like colorectal malignancy, inflammatory bowel disease, colorectal tuberculosis, etc. If we think we have to examine the anal canal immediately while the patient is having severe pain, it is always better to go for examination under anesthesia. Examination under anesthesia will open room for us for proper assessment of the anal canal, and furthermore, we can offer treatments like incisional drainage or exploration of fistula tract, etc. at the time itself. So it will help us in terms of treatment as well. Whenever somebody comes with painful perineal conditions, there are certain components of general care, irrespective of the individual renal conditions. Patient is in pain, so it's a must that we should offer adequate analysis. We should objectively assess the pain severity, and according to the pain ladder, we may offer pain relief, tailoring to the patient's sensitivity, allergies, etc. If you can ask from the patients who are having painful perineal conditions, the dreaded experience they will tell you is trying to pass motion. So they will resist that temptation, and at the end they will become constipated, and the vicious cycle forms, worsening the patient's experience. So it is imperative that we should give stool softeners or laxatives so that patient can pass motion with minimal efforts. For patients with painful perineal conditions or patients who have undergone extensive surgery, we extensive surgery in the perianal area. So we advise the patients to get a wide mouth basin or container so that they can sit comfortably. You will ask them to fill that container with lukewarm water and dissolve at least half a kilo of salt, table salt actually I am referring to. And then we expect them to sit into the lukewarm water for at least half an hour. This will reduce the tissue edema and in return reduce the pain and enhance the healing. For an inflammatory condition or infective condition, we consider metronidazole as a treatment. But there is an added value for metronidazole also, even though it is not proven that it has got some soothing effect when a patient is in very severe pain. Now, we are moving into individual conditions. Sorry, I'm having some trouble in navigating. So this image is showing acutely thrombosed external hemorrhoids. You can see a bleb-like structure at the verge of the anus. You can see the anal opening at the 3 o'clock position of that bleb. So this bleb is the one that gives very severe pain to the patient. If we explore the history of the onset of this pain, the patient will typically tell, I was struggling and straining to pass motion. All of a sudden, I experienced very severe pain and I noticed this bleb formed. And now I am having agonizing, throbbing pain, which is preventing me to do day-to-day activities. This is a typical story we hear from patients. This is what actually happens when a venous plexus or vein in the external hemorrhoids ruptures and forms this hematoma. If the patient is presenting within the 24 hours, there's always a place for small incision and squeezing out the blood clot under appropriate anesthesia. It may be local or it may be a regional one or general anesthesia. But once we squeeze out, the symptoms will subside to a great extent. But if somebody is presenting late, and whenever we are examining, this bleb is not tensed and it is shrinking, then we can give our general care with adequate analgesics and stool softness and reassure the patients saying, look, this is just a hematoma, a blood clot that will be getting absorbed gradually, so pain will be gradually vanishing. But we should warn them to avoid constipation to prevent similar episodes. Another painful perianal condition is anal fissure. When I was talking about the anatomy of the anal canal, I was telling you that below the dentate line, the enoderm is very sensitive. It is supplied by the somatic nerve supply. When our patient is passing hard stools, there's a tendency that there may be a tear or linear laceration. So, patient will get acutely severe pain. There are two types of fissures. One is acute and chronic. If the symptoms are persisting for the less than 3 months, we usually call it as acute fissure. If the symptoms are persisting more than that, we consider as chronic fissure. The next image is showing you the acute fissure. By the red arrow, I have pointed out a longitudinal tear extending into the anal canal, starting from the anal wedge. You can see some slough also. This is an acute fissure. Usually, we see a fissure at the 6 o'clock position whenever the patient is lying on the lithotomy position. But in females, we are seeing these fissures at 12 o'clock position as well. However, if someone is having fissure in clock position other than the 6 and 12, we should suspect some sort of underlying pathology like inflammatory bowel disease, tuberculosis. The next image is showing a chronic fissure. You can see the fissure with a skin tag. We call it a sentinel tag. Whenever we are examining a patient, if we see these tags, we will get to know immediately this patient had a long-standing anal fissure. So the management-wise, it's a difficult condition to treat. Most of the time, we offer conservative management at acute stage. Not only the management plan I have given earlier as a general management care, specifically for anal fissure, we can offer local applications like topical applications containing either GTN or calcium channel blockers. Those applications will relax the sphincter muscles and improve the healing. However, for a refractory anal fissure, which is not amenable to these conservative managements, we may have to go for certain other interventions. One option is botulinum toxin injection. It has got some proven value. We will provide appropriate anesthesia for the patient and examine the anal canal. Sometimes we scoop the base of the anal fissure to enhance the healing of the anal fissure. Then, by the side of the anal fissure, And into the intersphincteric groove, we inject botulinum toxin. It will relax the muscles and enhance the healing. As a last resort, actually, in that surgery, we divide and release the part of the internal sphincter. Whenever we are offering invasive internal sphincterotomy, we should alert the patients. There's a possibility the patient may end up with either flatus or fecal incontinence. Anyhow, if no conservative measures or minimally invasive treatment options are not working, we may have to offer this surgery for the patient. The next one is thrombosed or strangulated internal hemorrhoids. Whenever I was showing you the image of the anal canal, I was showing a venous complex plexus named as internal hemorrhoids. These venous plexus are aligned along the arterial supply of the lower rectum, and they form the anal cushions. So these anal cushions can prolapse. Anyhow, they are originating above the dentate line. So most of the time, early stage hemorrhoids, grade 1, first degree or second degree hemorrhoids are painless but present with lump and fresh PR bleeding. But once these prolapse hemorrhoids, they thrombose and strangulated, patient will be having severe pain. Patient can't sit properly, patient can't concentrate on the activities. So there are two schools of thoughts regarding the management. Traditionally or conventionally, we try to offer them the conservative management, pain relief, analgesics, laxatives, and hypertonic saline application to reduce the swelling and the sit spots, etc. But there's a place for surgery as well. But surgery should be carried out with extreme care. Reason is there will be extreme swelling and tissue edema, and large lumps may be protruding through the anal canal. Over enthusiastically, if we go and remove those lumps, we may not be able to leave behind adequate amount of intact anal mucosa. So later on, patient may end up with anal stenosis. So whenever we are doing emergency surgery for hemorrhoidectomy, especially for thrombus strangulated situations, we should be extremely careful not to remove excess anoderm, prevent anal stenosis. I just added this image. This is the proctoscopic view of the internal hemorrhoids. It will appear as a reddish blue, very like bulb whenever we are withdrawing the proctoscope. Whenever we are going for a raw band ligation or sclerotherapy, we will be focusing on these structures. But this condition is not painful. Now we are moving to perianal abscess. This is very common conditions we encounter in our day-to-day emergency surgical practices. I have put this image to show you, even though abscess is readily visible, they have marked with arrows. There's a reason. Once a patient is under anesthesia, sometimes you may not be able to locate the maximum tender point. Even though in this image it is visible, sometimes we may not be having a pointing sign in the skin. So whenever we are examining, whenever we are asking from the patient where they feel maximum pain, it is imperative that we should mark that point so that the person who is doing the examination and anesthesia can explore that area and drain any deep-seated abscess. Furthermore, on the abscesses, There's a condition called hidradenitis suppurativa. It's a skin related condition. It can also present with features of perineal abscess. In the perineal area and axillary area, patients we are having apocrine sweat glands which can get infected and give rise to this condition. So we should be able to differentiate from proper perineal abscess to hidradenitis suppurativa. Abscess is not a single entity because depending on the locations of the abscess, management differs. A superficial perineal abscess warrants simple adequate incision and drainage. But sometimes we may see abscesses in the ischiorectal fossa, intersphincteric area, or submucosal abscess high in the lower rectum or in the high in the anal canal. At times we come across with supralevated abscess. So we offer either drainage through the skin or through the anus if it is easily accessible through the anal or rectal mucosa. For an ischiorectal abscess, the worst case scenario is they may end up with horseshoe abscess around the anus. So we may have to release the whole set to get good drainage. So when it comes to perineal abscess, we should offer examination and anesthesia of the anal rectum, and we should place adequate incision and drainage promptly. Then we can give a course of metronidazole for 1 week to settle down the infection. But once we have done the acute stage drainage, patient may end up with a non-healing wound. That will tell us there's a fistula. Fistula is an abnormal connection between two epithelial surfaces, you all know. Here it's the skin and the anal canal or rectal mucosa. If someone comes with this sort of image, we should suspect fistula in anal. They may give a past history of abscess drainage or they may not give. But it is imperative that we should deal with this fistula as well. Because even though fistula per se may not be painful, occasionally that external draining site may get obstructed, so they may end up with abscess again. This is good source law. If we assume the patient is lying on the lithotomy position, if we draw an imaginary line between 3 and 9 o'clock position, the fistula openings anterior to the lining will be opening into the corresponding clock position. But if it is a complex fistula and if the external opening is mainly in the posterior or below the imaginary line, they always tend to open at 6 o'clock position. There are exceptions also, but it is good to know about this law. Based on the internal opening site, we can categorize fistulae into low anal fistula and high anal fistula. The low anal fistula are the ones which opens below the dentate line. Here you can see the dentate line. The superficial fistula can open below the dentate line. Superficial anal fistula or low anal fistula can be laid open without minimal damage to the anal sphincter. But the situation may be complex. The fistula tract can go between the two sphincters, internal and external sphincters, and may have transsphincteric component as well. Some high anal fistula can open into the rectum above the pelvic floor. Whenever we are dealing with these fistula, we should be careful. If we go and release or lay open these tracts, we may inadvertently damage the anal sphincter, and at the end, patient may end up with anal incontinence. So here at acute stage, whenever there's a cavity or collection, we will go for draining ketone. Once the inflammation and cavity settles down, then we can convert the draining ketone into cutting ketone. So without without major damage to the anal sphincter, we can get rid of the fistula. Usually, we offer as a stage procedure, but there are novel techniques. We can seal with anal plugs. We can go for laser treatment, but we should alert the patients. These treatments are not completely foolproof. There are chances patient may get recurrences. Now we are looking at the prolapsed rectum to the anus. Rectal prolapse per se is relatively pain-free, but when it is irreducible and strangulated, patient will be coming with very severe pain and it's a surgical emergency. Usually, we will be able to reduce the rectum without any trouble. But once it is strangulated, it may be difficult. So, in the clinical scenario, whenever we are receiving patients with this sort of complaint, it is a bit difficult for us to differentiate between the thrombosed prolapsed hemorrhoid and strangulated rectal prolapse, especially when the size is very similar. If you look carefully, the rectal prolapse will be having mucosal folds on circumferential arrangement. If you look at the prolapsed thrombosed hemorrhoids, the ridges will be longitudinally placed. And if we palpate gently without causing pain to the patient, we can identify the full thickness of the rectum coming out of the anus. This is how we differentiate between the prolapsed thrombus hemorrhoid from the strangulated rectal prolapse management. For a strangulated rectal prolapse, sometimes we may have to resuscitate the patient and take to theater. Under appropriate anesthesia, we may have to go for a resection called altomia procedure. At your level, it is always better to know how to identify and differentiate so that you can direct the patient for appropriate care. This image is showing perineal necrotising fasciitis. It's a part and parcel of venous gangrene. You can see the anal canal floating among the necron. This condition is also extremely painful. We see more often in diabetic patients. We may have to do extensive wound debridement and we may have to achieve soft tissue cover and skin cover after assessing the tissue loss. This is again another painful perineal condition. Proctitis is also present with pain, but there are several causes for proctitis. One is sexually transmitted diseases, which can predispose to proctitis. Previous days radiotherapy for prostate cancer or cervical cancer can end up with proctitis along with rectal bleeding. Inflammatory bowel disease is obviously having some components of proctitis as per the involvement of the bowel segments. But food-related infections can also lead to non-specific proctitis. Whenever we divert the fecal streaming for various reasons, let's say we offer a diversion stoma, defunctioning stoma, or an obstructive lesion or for any other reasons, for incontinence, etc. Patient may end up with diversion, colitis, or proctitis. These conditions can also present with painful perianal situations. Another difficult condition we come across is proctalgia fugax. It's an idiopathic condition. If we explore the history of the patient, they will be telling you that patient will be getting excruciating pain which lasts for seconds to several minutes. It may go up to 90 minutes as well. So they will feel very severe pain at the anus, disturbing their activities, and they can't concentrate on anything. They can't sleep. But later on, it completely vanishes without any intervention. All other investigations, assessment may show normal findings except for high anal tone, but anorectal manometry will be perfectly normal. For these conditions, we usually offer supportive management along with reassurance, saying that this will not cause any long-term sequelae for the patient. So we can offer six baths. We can offer topical applications containing GTN or calcium channel blockers so that patient can get pain relief at the time whenever they use pain. We should not forget about the anal trauma. A patient who had a fall from height or a spike injury can present with pain at the anus. People insert various items into the rectum. I have removed Coca-Cola bottles, toilet brushes from the anus. So we should suspect foreign body insertion also. Patient may be having associated psychiatric conditions also. So we should focus on that aspect as well. A person who is having anal sex can also can have anal trauma and end up with painful anus. Not only that, we undertake multiple surgical procedures around the around the anus and the perineal area. So after the surgery, patient may come with pain, ongoing rectal bleeding, hematoma formation, especially after sclerotherapy for a painless hemorrhoids, or due to pain, patient may avoid passing stools and coming with fecal impaction. Such patients will be telling us they are having throbbing pain at the rectum and the anal canal, and they are unable to pass any stool satisfactorily, but few drops or some amount of liquid feces is leaking out without their control. Then we should suspect fecal infection, and we can prescribe them the disinfection regime with Alcolex and clean enema, etc., so that will relieve their pain. Or patient may come with urinary retention. We see this situation, as I mentioned you earlier, after a hemorrhectomy, elderly people come with urinary retention. So whenever somebody comes with urinary retention, we should ensure that we should ensure that we are giving adequate analgesics for the pain following hemorrhoidectomy so that they can pass urine without any. There are certain conditions which are not directly related to anal canal but can be perceived as pain in that area. This is just the list: perianal abscess, oxydynia, Bartholin abscess, and herpes zoster of the perineum. I should tell you one story. Once I got a call from GP in UK saying that there's a young guy coming with perianal pain, and they have found out he has got abscess with redness, tenderness, swelling, etc. So they have prescribed one antibiotic. They have reviewed in 5 days' time. Symptoms are worsening. They have added upon the second antibiotics also, but no response. And now the redness is spreading into his scrotum as well. I told him to send the patient across. On examination, I found it is herpes zoster. So we should be careful when we are assessing these patients so that we can direct the patient appropriately for the appropriate care. So the take-home messages I would like to tell you all after this talk malignant lesions can coexist with benign pathology. The presence of pain per se may not exclude the presence of malignant lesion. So, we should handle the situation appropriately with adequate analgesics and according to a working diagnosis based on our clinical assessment. Later on, we should offer them endoscopic assessment to rule out any malignant lesions. This is a must. Even though patient is perfectly normal, always do a digital examination once the treatment is completed successfully, and you have to refer the patient or direct the patient for an endoscopy. Here, detailed clinical assessment itself will point towards a possible pathological assessment in the acute setting. If we focus on the symptom, most of the time we can come at a diagnosis. Again, the pain is a very severe one, and we should offer appropriate care promptly so that we can ensure the good quality of life. Thank you.
Thank you for your very informative lecture, sir. You explained all the details very clearly and very practical manner. So we have one question. What are the analgesics prescribed?
So that's why I didn't commit myself to analgesics, because NSAIDs are the best choice, provided the patient is not having any peptic ulcer disease or anything, or renal issues. But we had to go along the pain ladder. Opioids, whenever we are using for very severe pain, we should be careful. They can render the patient constipated, which can in return worsen the painful perianal condition. So we should be careful whenever we are prescribing analgesics. So it's a tailor-made or individualized regime we can offer based on the patient's preferences, patient's uh, allergies and disease conditions. And there's one option: we can offer anal block if facilities are available. But we should warn the patients that it's an invasive thing. Again, patient may end up with abscesses due to infections we introduce whenever we are injecting analgesic materials. So anal block is one option, but we should warn the patient regarding the risk of developing abscesses. Anything else?
Yes, we have few more questions. So, sir, these are the questions which participants have sent us in the pre-survey.
Thank you. I'll go one by one. I'll go through one by one. So, how we can prevent fistula formation? Yes, fistula may be an idiopathic phenomenon or a presentation of an underlying pathology, like tuberculosis, malignancy, or inflammatory bowel disease. So, if we identify an underlying cause, we should treat that cause appropriately. Tuberculosis with anti-tuberculosis medications. Inflammatory bowel disease, we should optimize the care of inflammatory bowel disease. And malignancy, we have to deal with accordingly. For an idiopathic fistula, which is presenting with perineal abscess and which opens up into the anal canal and the skin in both directions, then the best way is to avoid constipation. We often see patients who are having constipation end up with fistula formation. Do all perineal pain need medical intervention? That depends. I have mentioned you about the proctalgia fugax, which is an idiopathic condition. We do not have a definite management for that. But we have to explain them. We have to rule out other pathologies which can end up with painful perineal condition. If we do not find any other obvious cause, then we can reassure the patient saying that this condition is not going to give you any long-term problem, but transiently you will be feeling extreme pain. So we can offer pain relief or topical applications to get the pain relief whenever the patient experiences pain. The fourth question is how to manage complex perianal fistula. Whenever somebody comes with very complex perianal fistula, we suspect an underlying problem. So we do an endoscopic assessment to rule out any inflammatory bowel disease or inflammation in the lower rectum or malignancy. Then we offer the patient the examination and anesthesia. We explore the tracts using either hydrogen peroxide or gentle probing with lacrimal probes. And we will tack all those tracts whenever possible with draining cetone, and we will take a sample of the tract for histology. Histology itself may tell us the reason for the complex nature of this fistula. For example, we have diagnosed TB, tuberculosis, on the histology of the fistula tract. The fifth question is difficulty in differentiating external hemorrhoid from the skin text in OPD settings. True. If we dig into the history with the patient, they may tell us the history of pain suggestive of anal fissure. So whenever we are examining or inspecting the perineal area in our clinical setting, we can see the tags and the depression in the anal canal, which will be showing the past or healed fissure. If it is external hemorrhoid, most of the time it will be painful. So based on the history itself, we can differentiate. External hemorrhoid, sometimes you can get keratinized and thrombosed, so it will be like a heart mass. The skin tag will be a very slender, thin structure. Can we identify retrospectively also if we can do digital examination without any pain for the patient, we can feel the past or healed fissure at the site of the skin tag. That's why we call it as sentinel tag. What are the resolving conditions and the duration of observation? What are the conditions that need emergency treatment? Good. Most of the painful perineal conditions require emergency treatment. But whether we are going for surgical intervention or not is the question we are supposed to answer at that point. If it's a perianal abscess, we should offer them examination and anesthesia of the inner rectum and drainage accordingly. If it is a fissure, we can go for conservative management, observe. If it is presenting as the first presentation. But if it's a long-standing problem, affecting the patient very much and disturbing the quality of life of the patient, then we can discuss with the patient whether to go for an intervention, which either like botulinum toxin injection or a lateral internal anal sphincterotomy. So that depends on the patient's presentation, severity of the pain, and the nature of the underlying pathology. But most of the painful perineal conditions warrants emergency treatment, I will tell you. Perineal pain in females when sitting down with all the scans and tests are negative. Surely, I'm not sure about this. Perineal pain in females sometimes may be related to their past episiotomies and so on. Or there may be other hypersensitivity issues for females. But as far as anal canal and perineal structures are concerned, if we go for a proper assessment with clinical assessment with history and examination, and if you do the relevant examination, investigations, and if you rule out any significant pathology, we can go for reassurance and pain relief for the patients. But it is the territory of gynecologists for them to look from their point of view whether they have got any other problems to sort out. What is anal fistula? Anal fistula is an abnormal communication between the skin and the anal canal. The pathological definition of fistula itself, abnormal connection between two epithelial surfaces. So here one surface is skin, other one is anoderm or anal canal mucosa. That's why it's called anal fistula. If it is having only one opening, we will call it as sinus. Here in anal fistula, we expect to see two openings. How to manage rectal bleeding in primary care settings? This is based on how much patient has, sorry, how much blood patient has lost and how quickly the blood is passing and how hemorrhagically stable the patient is. Sometimes you may not be able to manage at the primary care settings. So we have to transfer the patient to an appropriate care settings, either to a hospital or somewhere. But for your purposes, if someone comes with extensive bleeding following a hemorrhoid surgery or fistula exploration from the anal canal, and if you think the bleeding is mainly from the anal canal or lower rectum, there's a trick. You can get a 22 or 20 size French size polycatheter and then lubricate the tip and enter and insert the catheter into the lower rectum and inflate the balloon with 30 cc of distilled water or normal saline and pull the balloon or pull the catheter snugly to fit into the convergence of the lower rectum. So that will compress the venous plexuses and the vessels gently. So rectal bleeding will stop temporarily. So that will give you some time frame or time lapse so that you can transfer the patient for appropriate care. This is a simple trick that can help us, provided that bleeding is mainly from the anal canal or lower rectum. But it will not work for bleeding from higher ups. So we should direct the patients immediately for appropriate care. Management of rectal prolapse in primary care. The rectal prolapse is something that is painless. It becomes painful when only it gets strangulated. For rectal prolapse, with gentle pressure, we can reduce the prolapse into the anal canal, into the pelvis. The main reason for rectal prolapse is long-standing constipation. So we can address the constipation with single or double laxative so that patient can pass stools without any efforts. So the rectal prolapse may not reappear. But at the same time, it is always better to get surgical opinion regarding the definitive care or resection or transabdominal procedures to correct the prolapse. However, if somebody comes with strangulated prolapse rectum, it's a surgical emergency. So I feel the primary care may not be appropriate to handle that patient. The patient should be transferred to a surgical care. Management of painful lumps in perianal regions. The painful lumps may be due to various reasons. So if it is infected and abscess, you can go for drainage. But there are other conditions like perianal warts, skin conditions like hidradenitis suppurativa. So it is the must that we should be able to identify the exact nature of the problem so that we can direct a patient to appropriate specialist. For example, if it is perianal warts, a dermatologist will be able to handle. If it is hidradenitis suppurativa, we always get the help of our plastic colleagues. So we will exercise and we will offer skin graft so that the wound will be healing quickly. In such situations, as surgeons, we offer diversion stoma to minimize the contamination of the skin graft site so that wound will heal without any issues. So it depends on the diagnosis we make. So what about pruritus ani? Yes, pruritus ani itself is a debilitating condition, but as it is beyond the scope of this lecture, so I didn't touch it. You know, sometimes patients may be having hemorrhoids, which may lead to pruritus ani. There are several reasons for pruritus ani. It can be due to discharge from the anal conditions, discharge, purulent discharge from the anal fistula, may be due to pinworms. So we should explore the possibilities and treat them accordingly. Sometimes we come across patients with pruritus ani with no obvious cause. So we try to manage them symptomatically. Internal hemorrhoids versus external hemorrhoids difference. Internal hemorrhoids are the hemorrhoids which are situated above the dentate line, forming the anal cushions along the arterial supply of the lower rectum. So we conventionally expect them to be there at the 4 o'clock, 7 o'clock, at 11 o'clock position of the anal canal, provided the patient is on the lithotomy position. The external hemorrhoids can occur at any clock position of the anus. Usually it occurs at the anal verge, not inside the anal canal. I have shown you in the anatomy of the anal canal, these plexuses are situated externally below the skin. So these plexuses can rupture whenever somebody is straining a lot to pass motion. So they are acutely present as thrombosexual hemorrhoids. Sometimes the internal hemorrhoids has progressed for a long time and they get keratinized. So we feel like it's a hemorrhoid lump with keratinized skin covering the humoral lumps. That also we see. For such situations, we offer hemorrhoidectomy. So we will excise the part of the keratinized portion of the internal hemorrhoids also, leaving behind the appearance of clover leaf. It may be too complex for you all to understand. While we are leaving behind the tissue breaches, intact tissue breaches between the humoral lumps while we are excising. So it will, at the end of the surgery, the anal canal will appear as the wound will appear as a clover leaf appearance. So there we would have removed part of the keratinized internal hemorrhoids as well. CRP level is normally increased in inflammatory bowel disease or irritable bowel syndrome. In irritable bowel syndrome, CRP will be normal. In inflammatory bowel disease, CRP will be elevated. Irritable bowel syndrome is something related to functional bowel disorder. So there will be no inflammatory or infective process going on. So patients will be having perfectly normal inflammatory markers. I'm referring to irritable bowel syndrome. But in inflammatory bowel disease, there will be extensive inflammation going on, and it may involve terminal ileum, segments of colon, depending on the pathology. It may be Crohn's disease or ulcerative colitis. So people may present with various manifestations like perianal abscess, perianal fistula, perianal fissure or fissure in ano, or proctitis or pancolitis, etc. So in such situation, CRP will be elevated, not in irritable bowel syndrome. How to approach every condition as primary care doctor and when to refer to specialists. How to manage the conditions as a house office. Whenever we are coming across a difficult situation, either in a clinical scenario or either in surgery, we always tell ourselves, always stick to your basics. So, in the primary care level, as a house officer, we should get a good history, analyze the symptoms, and look for the underlying pathologies. When look for any other associated medical conditions, any medications which can predispose this condition. So, if we do a proper clinical assessment and examination, then we will be able to identify the condition. Then we can refer to appropriate specialist. So, for a fissure in ano, if the patient is minimally disturbed, pain is amenable, at primary care level itself, you can treat, provided you are good with your diagnosis. Then later on, you can advise the patient to see a specialist for an endoscopic assessment so that we can rule out any other underlying pathologies. So for house officer, there will be always supervision. So there will be seniors to help them. So if you are not sure, please go for help. Even for experts, we do not stop at our level. Please always go for second opinion. Please speak to our seniors, our trainers, and send the patient across so that they can assess independently and help the patient. So there shouldn't be no ego or problem whenever we are getting second opinion. It's always for the betterment of the patient. Can anal malignancies present like this? Yes, true. It's very, even though there's a general belief that malignancies are painless, anal malignancies can present with pain. That's why initially at the very beginning I told you there may be an underlying malignancy. So it's always better go for a reassessment once the pain settles and do the appropriate investigations. How to manage the pregnant women with painful perianal conditions. It's a very common scenario we come across. Once the fetus increase the intra-abdominal and pelvis pressure, the patient will be coming with either fissure or prolapsed hemorrhoids. We try to manage them as much as conservatively without offering any surgery or interventions. So, sitz baths, pain relief, analgesics, and minimally invasive injections or band ligation, etc. if the bleeding is very severe enough. But following delivery, we will offer them the appropriate assessment with endoscopy and so on, so that we can help them to prevent further progress of the disease. Sorry, I mean, we try to defer any major invasive procedures during the pregnancy. We'll try to manage conservatively, and following delivery, we can offer the appropriate treatment. So, sitz baths, yeah, the question is, it's already answered. Thank you. We can use it. It is helpful.
Thank you very much, sir.
Thank you very
Our
much.
sincere thanks to Dr. V.Thusyanthan, consultant gastroenterological surgeon, Teaching Hospital Jaffna, for his excellent lecture and the precious time.
Thank you.